Hello, welcome to Session 7 of RIO 2024 U.S. Focus. I'm Suneet Mittal from the Valley Hospital in Paramus, New Jersey, and the chair for the next few sessions. In this session, the focus is RF and mapping for PAF treatment. I'm delighted to be joined today by Luigi Di Biase from Montefiore Medical Center in New York City and Pasquale Santangeli from the Cleveland Clinic. Hello, gentlemen.
Hello.
And a warm welcome to Rodney Horton, our case presenter for this session. So without further delay, I'm going to hand it over to Rodney to take us through the case. Rodney, welcome.
Thank you for having me for this. I was asked to talk about mainly the workflow for using radiofrequency and specifically the Qdot ablation catheter for mapping and ablating atrial fibrillation. The case that I'm presenting is a 23-year-old gentleman. It's a bit unusual, but the workflow doesn't really change. He has a history of a non-obstructive cord triatriatum and an atypical flutter. He's had a prior flutter ablation, and he was here for a paroxysmal drug refractory AFib. He was refractory to flecainide therapy. If you look down at the bottom, you can see a little bit of that cord triatriatum that you, if you ever have seen it, that's basically what it looks like there. So in this case, we are on the bottom left, you can see intracardiac echo. We're basically in the right atrium looking across into the left atrium. The bottom middle screen shows a fast anatomical map using the Qdot mapping system. And we're using a circular mapping catheter. That's simply what we elected to use. You obviously could use a splined-based catheter for this. The top shows, the top middle at least, shows the recordings from the circular mapping catheter. Technically, I don't have any other mapping catheters in there just yet. One of the unique aspects, individualistic aspects of using this particular mapping system is if you don't have a magnetic sensor on the catheter, you won't actually be able to see electrode only catheters. So you have to create what's called a matrix, where you're telling the placing a censored catheter into the heart and then telling the computer where the location of the sensor is relative to an electrode. Once it creates that matrix, then you can place an electrode only catheter in there. So here we are, I'm just going to fast forward a little bit because we really don't have enough time to go through all of these videos. This is going transseptal. On the bottom right, what we've done is we've already gone transseptal once. You can see a little purple or a pink mark, which shows where that transseptal puncture was. I personally do a double transseptal. I know plenty of very skilled people that use the single transseptal and will double access the left atrium. I prefer doing two separate sticks. It doesn't take very long, and it eliminates the catheter to catheter interaction problems. So once we're on the left side, I'm using the same circular mapping catheter to create a quick geometry. And again, I'm just going to fast forward here a little bit because some of the details of this are a bit redundant. So far, I haven't done any ablation at all. This is simply creating the geometry, something with which we can build upon with the ablation. By doing it this way, I'm not really required to use fluoroscopy. This is a technique that we sort of developed about 15 years ago to sort of eliminate fluoro. It's valuable to patients, is more valuable to my back, to be honest. I did it to help preserve my career. Here's going across. Once we've created a geometry, I use the Qdot catheter in the left atrium. I'm sort of filling out a little bit extra geometry here. Now, what you can actually see is that I prefer to look at this using the points. I just want to see exactly where the points were that are used to create the geometry. That way, if there's any bloating that the shell might generate, I can sort of look past that and see exactly where the catheters were so that I'm not confused by that. This is actually delivering ablation lesions with the Qdot catheter. I'm going to kind of fast forward here a little bit because I just don't want to run out of time. If you can see in the top middle, we've got what you're seeing there is the yellow is actually electrode information from the right atrium. Down the bottom is the coronary sinus, and then in the middle, the green is the information from the circular mapping catheter. We place the mapping catheter in the pulmonary vein, and we're simply delivering the ablation lesions. One unique thing about the Qdot is that we're really just looking at catheter and implied tissue temperatures there so that we know when we have a good lesion there. This blue catheter that you're seeing right there, that's actually co-located with the temperature probe within the esophagus. So we've got a sensored catheter aligned next to a temperature probe. So while I don't think you actually have to always measure temperatures from the esophagus, this is our standard, and this is just, I'm showing you the approach that we use. So we're monitoring esophageal temperatures because this is a thermal based, this isn't PFA, this is thermal based. So you're literally burning the muscle tissue. You could get transmissive heating of other structures, including the esophagus. So we're just trying to make sure that that doesn't overheat. And I'm just going to kind of fast forward here until we get to the point where that vein is isolating. If you look up here to the top, the live screen there, you can actually tell when the vein becomes silent. Okay, right at the end there, it did go silent briefly. I think we do have to go back to finish that. Okay, here's where we've gone through that vein silent. We're moving on to another vein. See, when we put the circular catheter in the right superior vein, we have independent firing. We actually even have some fibrillatory action that is in one of those veins. So I generally have always started with the right veins. Couldn't really tell you why. I just started doing it that way. So I isolate the right veins first, and then I move on to the left veins, and then the posterior wall. And of course, if you're going to ablate the posterior wall, which I guess still is considered controversial with RF, I think monitoring temperatures is probably a good idea. It's also a good idea not to stack the heating. So delivering thermal lesions on the posterior wall and then not allowing the deep tissues to cool before you deliver another lesion is probably a mistake. So if you're going to do that, the safe way to do it is to burn. And then if you do see temperatures rising, give it time to cool down before you deliver any more lesions in that area. That's the best way to avoid the deep lesions causing esophageal injury. So I'm just kind of fast forwarding there. So here we've got a completed lesion set. You can see in the on the left screen, we're on isoproternol, we're firing, but the firing in the vein is not one-to-one with the remainder of the right and the left atrium there. Here, I think we had to touch up a vein that had sort of reconnected, so we just touched up and re-isolated it right there. You see that in the, on the right screen. And then we usually just after isoproterenol, make sure that all of the veins remain durably isolated. Final lesion set was here, and that was the procedure. So we did the whole procedure without any fluoroscopy. I'm going to stop sharing so we can get back to the procedure.
Rodney, thank you very much for that case.
The way of doing it, yeah.
So can you just comment on a few things? Number one is, in this new era of PFA, how are you choosing between, achieving the desired ablation using this technology, versus PFA? And the other is, I believe your group early on had reported some issues with perforation, which allowed you to understand better how to optimize delivery of energy with this catheter. What can you teach the audience about that?
Yeah, so it's when I agreed to give this talk, I wasn't given the topic yet until afterwards. I thought that was kind of funny because the new kid on the block is of course pulse field, and pulse field is sort of the exciting new toy, but it's also a very powerful toy. So having said that, though, there's still a role for radiofrequency. I don't think that we have to suddenly pretend that we didn't spend 25 years using it as the gold standard for managing rhythms. Moreover, I think that one of the advantages of PFA is that I describe it as a bit of a howitzer, if you're going to use a military term. So it's a large footprint, it's a deep lesion. It obviously has a lot of advantages. It has a few disadvantages that were alluded to in some of the other talks. With radiofrequency, it's more like a sniper rifle. So you're very precise. So if you're trying to ablate something where you don't want collateral damage around it, this is the way to go. Additionally, you can kind of adjust the depth of lesions. We've been doing it for a long time. So areas that we want to get all the way through the tissue, we have a lot more experience using radiofrequency than using the PFA technologies. I mean, that's going to change in years. Now, to get to your question about how to avoid perforations, Qdot's a very powerful catheter. And so you can do lesions that are very short, and you can sort of dial in how deep you want to use it, depending on how much energy, what the wattage is, and how long you're delivering the lesions. But you also have to be very careful if you are very perpendicular to the tissue. So when you're basically pushing up against the tissue and you're delivering a lesion, you can get very deep heating very quickly. And where we did see steam pops were largely when the orientation of our catheter was more perpendicular to the tissue.
Great. Well, while we're waiting for the audience to put in questions to the Q&A, I'll turn it over to Luigi and Pasquale to see what questions they may have for Rodney.
Yeah, so I wanted to come back to this, it's a very powerful catheter, this is true. And to your prior question, to help the audience, Rodney explained it very well, but there's also something else that we can add, which is when you put your patches, if you have a very low impedance, I would say below 80, before you apply energy with this catheter, you have to reposition the patch in a different position, or you may have to add a second patch, because otherwise the current that you're going to give to the tissue may be too much. And that is something that we were not putting a lot of attention before. But with this catheter, I think you had to put attention to the baseline impedance of the catheter before you apply energy. And that's something that can be easily done to avoid possible, perforation. The question for Rodney, do you use 50 watts or 90 watts based on, the anatomical location, personal preference? I personally like to drag and use the 50 watts modality and go around, and maybe go 90 watts in the posterior wall. But I want to know, what is your workflow, what you feel saying to the audience?
So one of the things that is kind of unique about this ablation system, really, with the Qdot, I'd call it a system because it has its a unique generator as well, is that you have the option of using these two different modalities. They have what's called Qdot Plus, where you can deliver the high power for very short duration. The idea being that you're getting superheating, but very short period of time, so it's not very deep. And so the thought is you can do that on the posterior wall if you're dealing with tissue that's not very thick and you don't want a deep lesion. It makes sense to use that. Now, having said that, I'm a little bit like you, Luigi. We both worked in the same lab for a long time, and so we have some similar characteristics. I tend to leave it on the 50 watts, and I drag it, and I spend less time. So I use shorter duration from lesions, particularly on thinner areas where I don't want deeper lesions, than I do on other areas. Now, one comment to what you did say, which I was, I think, an excellent point about the skin patches, because radiofrequency is an alternating current, is unipolar. It's delivered between the tip of the ablation catheter and a dispersion, a indifferent electrode that's on the surface of the skin. What we actually saw is that with this generator and with this Qdot catheter, if you use one patch and the one patch is not large enough or completely in contact with the skin, you can also have the opposite problem from what you described, which was a steam pop. You can actually have a third-degree burn on the skin. And so I think that is something that we honestly never saw with the prior systems. And because of that, we actually used two patches to try and double the surface area on the skin. And again, it's a weird thing, but we hadn't seen it in 2 decades with the other systems. And we actually did have one patient with a third-degree burn when one patch was applied and probably was not fully in contact all the way around. So the surface area of the indifferent electrode was inadequate to disperse the heat.
Pasquale, what are your thoughts?
Yeah, first of all, great talk, Rodney. You've been a pioneer of fluoroless approaches. I've been doing this I watched you doing it. It's actually more than 10 years ago when I was there with you. The question is, can you just instruct us what your approach is in patient with intracardiac lead, like atrial lead and multiple leads? And also now in these days, when you have a flutter patient, atypical flutter, what is your go-to energy source? You go with a ref, you go back with TFA. So please.
Excellent question. So yeah, we have been doing, well, first of all, let me address the leads part, because I think it's an important one. One of the things when I do cases, and I guess I'm going to confess that sometimes I get into the rhythm of doing cases and I forget that the patient has leads until I see the leads with intracardiac echo. And when I do, I'll immediately ask the monitor, okay, how old are these leads? Because if you have leads that are less than 6 months old, no matter what you're doing, you can knock them free. It is possible to do. And so the one I showed you, the case that I showed you was with a circular mapping catheter, and a circular mapping catheter can loop around these leads and potentially knock them loose. I will confess, I haven't actually knocked loose a lead using a fluoroless technique. Ironically, I have knocked leads loose while I was staring at it with fluoro. So it was sometimes they can happen no matter what you do. But I do think that the spline-based mapping catheters are a bit less likely to loop around things. I also have kind of modified, and really in the last 6 months, when I trained to do transseptals, we would put all the sheaths up into the SVC, pull everything down. And of course, if you've got an atrial lead, you can loop around that catheter, and as you're pulling down on that atrial lead. And so one thing I've started doing, because you really don't have to go into the SVC with intracardiac echo. So what I'll do is I'll actually place my sheath in the atrium where I know it's underneath the atrial lead. And then I will basically stare at the sheath of the intracardiac echo, advance the dilator in, and there's really no reason to go up into the SVC and run the risk of pulling things down. So that's really, so circular mapping catheters, a lot of torquing around and doing nonsense, and pulling down from the SVC. Those are the three things that can allow you to sort of wrap around a lead and then accidentally pull it out. Now, the other question, I don't remember what the other question was.
It's about atrial flutters. If you have you go for ablation now, or PFA.
You know, our group is kind of split on this, and I see both arguments for it. I have kind of come down on the side of, okay, if I have an atypical flutter and I have access to a PFA catheter with a large footprint, I kind of view it like, okay, I don't have to be that precise. I need to know pretty much where the flutter is, and then I can simply take out that area the size of a quarter and it's done. A little bit of almost a minimalistic approach. I'm sure guys like Sonny Jackman would blush at that. But half of our group is the opposite, and they'll sort of say, no, I want to know exactly where that is, use RF, use a Qdot catheter, and get rid of it that way. And I can see both sides of that. I will say that if you really know exactly where the flutter is and it's on a thick part of the atrium, like the roof of the left atrium, Qdot will burn through that probably a little bit easier than some of the PFA catheters do. Well, some of them have deeper lesions, so that wouldn't apply, but some of the commercially available ones aren't that deep. I think there is a depth problem with PFA, at least with some of the systems. And so if you do need a deeper lesion, as long as you're very precise, RF probably would be the way to go.
Sunil,
Rodney, if you are going to commit to RF, go ahead, Luigi.
Rodney, in this setting that Pasquale was mentioning about, you know, you've been a pioneer. We have seen you doing fluoroless procedures in 2010. It's almost 15 years today. You know, now we have like catheter, then map and ablate, and we have PFA. Then our hospital are trying to say, you know, you have to do cost-effective procedure. How comfortable do you are with doing a simple paroxysmal or first ablation PVI posterior wall, if you want, with the you know, the reconstruction of the left atrium with the eyes, and just going one catheter transseptal, do the Qdot that you just show, and you know, pace within the vein to demonstrate isolation. Do you think this is a viable way to do an effective procedure while maintaining a very low cost?
Yeah, so I'm not sure I understand all of the question. I think what you were asking is, how do we limit disposables, limit cost, you know, basically the per procedural expense to the hospital in a, well, either in a fluoroless environment where you do need some things in the body to provide information. I do believe that if you don't have fluoro, this has always been my mantra for the last 15 years, you have to replace it with something that's as good or better. Otherwise, you're frankly sacrificing safety. And so I think that with the PFA procedures, they're very ice heavy, in my opinion, because you really want the electrodes to be in good contact all the way around. You don't want electrodes dangling in the middle of the atrium. It's not because it'll cause a thrombus or that it will cause a stroke. It's because it'll cause double the amount of hemolysis. And so we worry about that. So the intracardiac echo, I personally prefer it in the left atrium because I think I can see a lot better that way. I know some of my colleagues don't. They leave it in the right atrium and they're happy with that. I think that's fine, but you have to have ice, which means that all of these things that we do, if I hadn't used ice in the left atrium for appendage closure, I would have been ill prepared to use ice in the left atrium for the PFA. So it's almost like everything we do has been built upon the shoulders of what we did 5 years ago. And so for me, I do think you can, I have done fluoroless PFA cases. I find them a little bit more of a pain, a little bit more of a headache for me. Unfortunately, you're trading either a headache going fluoroless or a backache using lead. I think that the current versions of PFA, they can be done. You can do them, and you can do them safely without fluoro, but you are very heavy on ice. You have to see exactly where the tip of the sheath is, because the sheath is relatively rigid. And so if you're not aware that it's up against a wall and you start pushing or twisting or doing something like that, something bad will happen. And that's avoidable. So I don't think that it's enough to say, well, yeah, I just don't want to use fluoro because of my back. No, you cannot. The patient deserves better than that. So yeah, until we have systems where we can see our sheath orientation within the construct, then I think that you either have to take longer to get the information with ice so that you can do it without fluoro safely. I think that it can be done, and I have done it before. Or you have to go back to a fluoro-based procedure until the technology is sort of caught up with what radiofrequency is perfected.
Well, Rodney, thanks very much. I think this is a great time to wrap up. You've shown a really beautiful case as usual. So I want to thank you, Luigi, Pasquale, for your insights. Unfortunately, that's all the time we have for this session today. But please stay tuned. The next session is coming right up.